Hi, David Rosenberg here for the Psychopharmacology Institute. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll look at the effectiveness and safety of lisdexamfetamine in preschool children with ADHD 4 to 5 years of age. The authors conducted a double-blind, fixed-dose study in 199 preschool children with ADHD treated with fixed-dose lisdexamfetamine, 5 milligrams, 10 milligrams, 20 milligrams, or 30 milligrams, or placebo for 6 weeks. While most psychotropic medications for ADHD are not FDA approved in preschool children, pharmacotherapy is increasingly being used to treat preschool children with ADHD, particularly preschool children 4 to 5 years of age. Nonetheless, there are still far too few studies that have examined the safety and effectiveness of psychotropic medication in preschool children with ADHD. And as stimulant medications are typically the first-line pharmacotherapy for school-age children and adolescents with ADHD, as well as adult patients with ADHD, this is a logical place to start. So what did they find? Well, first of all, lisdexamfetamine was well tolerated in preschool children 4 to 5 years old with no new safety signals. Also, in preschool children 4 to 5 years old with ADHD, lisdexamfetamine was significantly more effective than placebo in reducing ADHD symptoms. It's important to note, though, that while lisdexamfetamine pooled doses of 10, 20, and 30 milligrams were superior to placebo in treating ADHD symptoms, lisdexamfetamine was not as effective in preschool children 4 to 5 years old with ADHD as compared to school-age children and adolescents with ADHD. And interestingly, on the primary outcome measure in the study called the Clinical Global Impression Improvement Score, or CGI-I, even though there were more participants in the pooled lisdexamfetamine group who were rated as improved, these improved scores didn't reach statistical significance. The mean or average CGI improvement score was, however, significantly lower than in the pooled lisdexamfetamine group. So confusing, right? And what does all this really mean and how does it come together? The bottom line is this actually raises far more questions than it answers. And this is obviously a very tough population to study. And we know that if you do enough statistical tests, there can be a significant chance finding that may not, in fact, be clinically significant, but due to the multiple comparisons and the law of average, and the more tests you do, the more likely you're to find something. The authors appear to have controlled for this, but it still raises a lot of questions. And there are some significant limitations in this being a fixed dose rather than a flexible dose study, which is what is more commonly done in clinical practice. That is, we titrate a medication up or down, monitoring for side effects and trying to hit the sweet spot of maximal efficacy and minimal toxicity. In this study, lisdexamfetamine was titrated to a fixed dose. So the children could have been on suboptimal doses, either too low or too high, or possibly not long enough on the best particular dose for a particular child. And this was also a 6-week study, so that may not have been enough time to monitor for efficacy and side effects. Don't forget that this is an industry-funded study by the sponsor, with the research being funded by Shire Development and co-authors on the study being with Shire and the Takeda group of companies. Takeda pharmaceutical companies also provided funding for writing assistance for this manuscript, and the statistical expert on the study was also with Takeda Developmental Center Americas Incorporated. Bottom line, potentially very promising new lead, but not yet ready for prime time, with more study needed, especially in this vulnerable young population where behavioral and parent caregiver management interventions are recommended as first line before pharmacotherapy is considered.